So, hi everyone. I welcome you all to this first PAX International Web Symposium. And today we are going to discuss a very important topic, that is non-invasive ventilation in lung failure. And PAX has been already, doing a lot of educational activities and getting into the meaningful discussion in the field of respiratory medicine and the advancements in it. So definitely we'll be doing this the same this night, and I welcome you all for this wonderful event. And for this wonderful lecture on non-invasive ventilation, we'll have Dr. Sharmila Vitana from UK with us. And before we start this program, I request Dr. Deepak Talwar sir for the short introduction, because I remember after the PAX 24 was over, I was discussing with him that few of us might have missed a lot of meaningful lectures, and we failed to reach a lot of audience because not everybody can come to attend PAX offline, and their physical presence was missing. A lot of people were talking about it and requesting it. So Talwar sir came with this idea. So I would like to request him to give a brief introduction about this program and this thought about it.
Thank you, Kanishk, and good evening, everyone. As I promised you, reliving PAX 2024 is a reality, and we are going to do some key sessions, and one of the very important session is going to be with Professor Sharmila Vitana. The idea of this web symposium is that we will have that curated lecture which is on that particular topic, which is of great importance to all of us, and I have got the feedbacks for that. And of course, the very important and very enlightening thing would be a direct interaction with the key speaker, and today the key speaker is going to be Professor Sharmila Vitana. I know that there was, due to paucity of time, many of the faculties and delegates could not interact, so this is the time to interact. And we also will have the two panelists, and we have these two panelists also with us, and of course moderator will be there to moderate it. My job is just to introduce you to this new hybrid way of bringing this web symposium last Saturday of every month, and we will be reliving 6 of such episodes with our memories of PAX 2024. So over to Kanishk to carry on with the proceedings of today.
Thank you so much, sir. So now we are live, and we will be listening to Dr. Sharmila Vitana and her lecture on NIV in lung failure. So can we have the lecture, please?
In an absolutely fantastic session. It's been a privilege to be part of it. I'm so glad I bumped into you, Deepak, in the Respire sessions in February. A very complex topic. What I have tried to do is to try and make it as much palatable as possible for this time of day. I've brought in content from a couple of topics, and because the main aim is to tell you how to do this in the home or a day unit or an ambulatory setting. So I will cover once again, no disclosures, I will cover the following areas. We'll look into the causes of neuromuscular disease and multidisciplinary care, very much looking into motor neuron disease in this case. I will give you some guideline content based on the NICE motor neuron disease guidelines in 2019 and the American College of Chest Physicians published in Chest, a clinical guideline from last year. And we look at the modes, settings, and how you do this in a home care setting, very much based on some published data. Now, one area that is very important in neuromuscular disease as well as chest wall disease is chest physiotherapy, and this has to be a degree of highly skilled chest physiotherapy. So that is something you need to develop if you do not have. So I will touch a bit on cough assist techniques and mechanical insufflation, exsufflation, extremely important as non-invasive ventilation in this group. We'll briefly touch on advanced directives and telemonitoring. Now, neuromuscular disease is quite complex on its own device, so you need a neurologist to help you with the diagnostics. You need certain tests, MRI scans for the brain and the spine, diaphragm studies. You need your blood panel and the nerve conduction and the EMGs to diagnose this. So we generally work with the neurologist to do this. I think in your case you tend to set about doing it as on your own. So a broad spectrum there. This is the history and the evolution of non-invasive ventilation that I took from my guru, Professor Anita Simond, recommended reading material. You can see non-invasive ventilation actually started with neuromuscular disease. Somewhere in the 90s, there was a break change in published data in Duchenne muscular dystrophy, and mid-2000s in motor neuron disease. This is one area where there is no doubt whatsoever that non-invasive ventilation improves survival. Now, moving from 2014 to now for the last 10 years, what's come on is the volume-assured pressure support ventilation and the telemonitoring techniques and this sort of home or hospital-to-home community-based support structure for these patients. We looked at this data before. This is the trajectories that we talked about, and the two blue lines is what I'm focusing on, the rapidly progressive neuromuscular and the slowly progressive neuromuscular. But we'll very much talk about the rapidly progressive group because that's where you need to know how to get your service structure sorted. So this is the multidisciplinary structure that we spoke about before. You will see in the core team I have added chest physiotherapists, and that's extremely important, and we will talk about this briefly. The rest of the structure is very much what is recommended as per NICE, that you need a neurologist and a motor neuron disease, MDT. You need good speech and language therapy together with nutrition, together with what we call AAC or augmentative alternative communication techniques. The three go together. Then you have the orthotics and the robotics. Gene testing that we spoke briefly before, and palliative care is extremely important. Now, these patients, as time goes, become more and more ventilator dependent, and as they become ventilator dependent, you need more support from what we call community trachea ventilation team and mouthpiece ventilation skill. So guidelines from NICE for motor neuron disease, when do we set them up on NIV? You can see the thresholds are fairly simple. In terms of blood gas, you're looking at a PO2 level for those without lung disease of anything less than 73. With lung disease, it's 60. PCO2, 45 and above. With symptoms, you don't even need a 45. And then they do look into pulse oximetry. Now, this could be a TOSCA and you add the PCO2 on top of it. Now, you combine that with these lung function measures, FVC less than 50 but less than 80 if you are symptomatic. We spoke about the SNP pressures or the maximum inspiratory pressures. This is the device that I showed you before, which in use. The SNP, which you put, use the nostril and it's the inspiratory pressure measurement. The same device with a mouthpiece can give you the MIP, and these are the cutoff values. Now, one thing important is that these values are very useful in your follow-up to decide how fast the patient is declining. So, a reduction of more than 10 over 3 months. Another measurement is the peak cough flow or the cough peak flow, and 270 liters per minute is the value where it becomes significant that the patient is going to need support with NIV. This I put within brackets the famous erect and supine vital capacity drop. That's not given in the guideline. However, in practical terms, it's very useful. Next, what I have put is what I've done is to put the ACC guidelines published last year. These are clinical guidelines. There are 17 different guideline recommendations, but I have put what is important and relevant compared to the NICE into the oximetry or the sleep study data and your lung function data. And you can see NIV is strongly recommended. The cutoff value for the pulse oximeter is slightly high, and this is what we use, the 90%. And you can see there is the AHI number. If you have the PCO2, it's still 45, no change. There is a place for polysomnography if you do not find your oximetry or your capnometry to be positive. So if you do have a oximetry and a capnometry that shows what we call hypoventilation, remember a jump in your PCO2 of more than 7 millimeter mercury is good enough. So if this is negative that we talk about polysomnography. Lung function data is more or less the same, except that you can see the SNP MIP-MAP values are slightly higher. Now, early setup is better for this group of patients. There's a bit on mouthpiece ventilation and tracheventilation for those who need it more. So what I've done here is to use some published data to look at how we set it up. Now, this is data published in 2019, and what they're recommending is to go slow and low pressure numbers and then gradually build it up. But you can see these are patients who do not have much muscle function, so you do not need high pressure support values. This is another important thing, that patients with bulbar weakness, traditionally we think they will not tolerate non-invasive ventilation. The latest data is showing that they do benefit from it, and you need a degree of skill to set them onto it, but once you do, they do benefit from it. They need more inspiratory time than your obstructive disease, so the timed inspiration is high. This is how you target your treatment. This is, and you can see you use either your oximetry cutoff values or your PCO2. This is generally what we tend to use to see whether they are responding to treatment. Next, I'm showing. Where was I? Did I do something with this? Yeah, so next I'm using some data to let me just make sure, yeah. I'm using this data to show that patients with bulbar dysfunction do benefit from non-invasive ventilation. This data shows that the patients with no NIV versus on NIV a clear advantage in survival, and the patients with bulbar dysfunction, even severe bulbar dysfunction, do benefit from it. This slide is data published last year. An RCT to show you that, this is better, isn't it? To show you that patients who are started early have a survival advantage up to about 2 years. Now, 2 years is a lot of time for this group of patients who are rapidly deteriorating, and I'm also showing you this data to show you what the IPAP, EPAP values are. So a bit on cough peak flows. This is a simple device that you can use to measure cough peak flow, which is a measurement of your inspiratory pressure. Very useful in follow-up. You need a good seal. And this is techniques that are recommended in both NICE and ACCP on airway clearance techniques as well as management of drooling. There are quite a few different techniques here, all of which are useful if in combination. More about manual and mechanical insufflation. If you have a good chest physio team, you can deliver this. You can clearly see that it improves the tidal volumes and ventilation. Again, more about this on a very recently published research data from Lane Fox. You need to see that insufflation, exsufflation improves the cough peak flow and improves ventilation. A few words about Duchenne muscular dystrophy, one disease where NIV has transformed survival. Those who are born after 1991, they tend to survive 50 years or more. They tend to need, as time moves on, more time on ventilation, and this is where mouthpiece ventilation is helpful to relieve their pressure effects during the night time, and definite advantage in survival. I'm showing some data here. There are lots and lots of different modes of ventilation, and you can see this study. Lots of studies have been looked into. Most of it were most of it were based on, you can see the studies in 2020, so the setup was very much based on the NICE criteria. And what we are looking at is that regardless of the different types of ventilation, now we've talked about pressure support ventilation, we talked about the volume assured pressure support ventilation. This is another technique that is used in Europe, which is your volume cycled ventilation with a bit of PEEP. Regardless of the mode of ventilation, what they're showing is having NIV is better than no NIV in improving survival and quality of life. Not just that regardless of the mode, there is no difference in survival. What is more important is that the patient uses the NIV for more than 4 hours. So the duration of usage is more important. And I'm showing you this to show you that neuromuscular and chest wall disorders, this is restrictive lung disease, COPD combination, you can use different modes to improve these patients. A little bit on telemonitoring, you can see this is useful data where telemonitoring has helped in monitoring the tidal volume. Patients with motor neuron disease or without motor neuron disease, they have looked at the telemonitoring data in terms of the different settings. This is with the volume assured mode and the standard pressure support mode. What they saw was it's the number of hours that helped rather than the mode of ventilation. Lastly, the importance of palliative care could not be addressed more this is one disease where this is very important, that you need a good palliative symptom control team recommended. And to summarize, I think patients can survive longer with better quality of life. It's a lot of resource, however, just couldn't, in conclusion, the genius of this century has survived for this long and become such a productive contributor to the modern sciences simply for the advancement of what neuromuscular disease services have provided for the last, say, 50 years. Thank you.
You are mute.
So it was a wonderful lecture, and for us it was a revisiting of the sessions which Dr. Sharmila Vithana took a couple of months ago, and now we are able to listen to her again. So it was wonderful to hear her again and learn from her. And now I request my audience to write questions to us, because that we'll be discussing after we have finished the question answer session taken by our moderator. So now I would like to introduce our moderator and our expert panelist from India to all of you. And for moderating this session, I request Dr. Madhukar sir to be online, and he's there. Yeah, he's there from Patna. And for panel discussion, we have Dr. Samir Garde from Mumbai and Dr. Kashmira Jhala from Ahmedabad. So I request Dr. Madhukar to please take on this session and start with the question answer or the discussion, elaborate discussion, and share the insights with us.
Thank you, Dr. Kanisk. It was really amazing to hear Dr. Sarmila. She had such a brilliant talk. I heard her during the PECs also. And before I start this panel discussion, I must congratulate Dr. Deepak Talwar sir for having such a brilliant PAX 2024, where it was not only hugely attended, but also he brought into the conception of some of the topics where we pulmonologists find us difficult to cope with. And one of such was the NIV in restrictive lung disease Dr. Sarmila talked about. So after her talk, I'll just delve deep into the aspects of NIV, where we can learn the practical application of NIV in restrictive lung disease in general. So Dr. Kashmira, Dr. Kashmira, we would like to know what different settings in NIV we do apply in context of restrictive lung disease when we compare with the obstructive lung disease. So what different settings you have for NIV in restrictive lung disease?
Good evening, everybody, and I'm very thankful for this having opportunity to me, especially Dr. Talwar sir and PAC 2024. Um, Basically, as we all know, this NIV is nowadays very preferred mode of ventilation in even hospital setting also and ICU setting also. So NIV has a different mode of ventilation in which basically by CPAP mode, which will give continuous positive airway pressure and mainly used in the obstructive sleep apnea, as we all know. The bilevel positive pressure ventilation has a different type of mode, and in which we have a spontaneous mode, spontaneous time mode, pressure control mode, and EVAPS mode. So if we are talking about the difference between respiratory and restrictive and obstructive airway disease, then the most important is I'm going to superficially talk about this different mode, in which spontaneous mode, we all know the machine will augment the spontaneous breath, and this spontaneous BiPAP mode is basically fixed mode, in which we have to set EPAP and IPAP, and according to the machine will give the this set delivered tidal volume. And in this which is mainly used in the COPD or chronic respiratory failure, COPD with OSA and all these things. If we are talking about the spontaneous time mode, in which machine will give the patient will breathe spontaneously also, and the machine will augment the mandatory breath when patient misses the breath, and in which we have to set EPAP, IPAP, inspiratory time, and backup rate, and according to that the machine will give tidal volume to the mandatory breath only according to the inspiratory time. So this will tidal volume may vary in between each respiratory cycle, and this is also again used in obstructive airway disease, COPD, acute exacerbation, COPD with OSA, and also when there is a patient who have a neuromuscular diseases. But the pressure control mode, which is the most preferred mode in NIV setting, in which we have to set EPAP, IPAP, inspiratory time, and backup rate, and in this mode the machine will give pressure controlled ventilator or tidal volume at the constant time, and it will be triggered this both spontaneous breath also and mandatory breath also, both are triggered by the machine, and which will give constant inspiratory time. So set of tidal volume which will delivered continuously in this patient, and this is the preferred mode in chest wall
Kashmira,
diseases. And
Kashmira, please, I'll just come to a point where can we be very particular about the settings of NIV in restrictive lung disease, which differs from obstructive? What
so
settings we actually what settings we do in NIV for restrictive lung disease compared to the obstructive one?
So in restrictive lung disease, we have a preferred mode is pressure control mode, and in this we will set inspiratory time, which is more rather than this obstructive lung disease. So there is a continuous tidal volume will be delivered, and there is a because of that there is a less hypoventilation because of the constant tidal volume delivered.
To summarize, I would like to point it out that in restrictive lung disease, we tend to have higher IPAP, so that to compensate for the compliance decrease in the compliance for the restrictive lung disease, we do not apply higher EPAP in restrictive lung disease, and at the same time we the I is to E ratio, we do not prolong the expiration as compared to the obstructive lung disease. Because in obstructive lung disease, we need to have higher EPAP to open the collapsed airway. We do not apply higher IPAP in obstructive lung disease because the patient is already in dynamic ventilation, and I is to E ratio, we keep expiration longer than the inspiration so that the air trapping can be reduced. So this is the basic difference we have for the NIV in the restrictive and obstructive lung disease. So Dr. Samir, one important aspect of NIV in using the lung condition, whether it's restrictive or obstructive, is fixing of TI max. So how do you decide to fix the TI max in restrictive lung disease?
Yeah, that's a very valid question, Dr. Madhukar. First of all, thankful to Dr. Deepak Talwar and Dr. Kanish. It is great listening to your talk, Dr. Sharmila, and great interacting with Dr. Madhukar and Dr. Kashmira. So I presume that our audience knows the basics of ventilation and NIV, and with that I start with my answer. We can ventilate a patient in two ways. One is a mask with input and output. So there are two tubings. One is inward and one is outward. In such kind of situation, the leakages are least. So whatever settings you have set on your ventilator will be delivered precisely to the patient. This question of TI max, which is called as inspiratory time minimum and maximum, comes when there are leakages expected, especially when you are using a mask with a single tubing, which is very common when we use a typical portable NIV situation. So what happens is when a breath is delivered to the patient, there is a setting in the ventilator where after a certain amount of peak flow is given, say 25%, when the volume drops at 25% of that is where the expiratory trigger starts. That means the inspiration is over and the patient is able to exhale now. But many times because of the leakages, machine feels that no, I have not given enough amount of air, and it just continues with that inhalation flow. And that is when the patient and machine asynchrony starts, and that is when the patient starts becoming restless or breathless and is not settling down despite of your best of the efforts. So that is a time when there is tachypnea, when there is pH is not improving, or your PCO2 starts building up. Two ways. One is clinically this way. Secondly, nowadays, thankfully, these machines have graphics. So you can look at whether there is the peak and plateau, there is hardly any difference. At the end of inspiration, the exhalation isn't beginning because machine still is giving that inspiratory flow to the patient. So that, because of the leaks, first of all, take care of the leak. Do not really suffocate your patient by tying your mask very tightly. Of course, you can allow a little bit of leak in such masks, but you set your this TI max to such a level, that is, say, anything between, say, 1 to 1.2 or 1.3 seconds, that the machine now understand that 1 second is over or 1.2 second is over, and let me stop giving my inspiratory flow to the patient, and it starts decelerating, and that is when the exhalation happens. So clinical and graphics, these are the two ways where you can take your call about setting a TI max, especially when you are ventilating a patient with a single tubing, with the exhalation valve in the mask itself.
So a wonderful answer, Dr. Samir. So what we could understand from your point, one, we set the TI max to establish the synchrony of the patient with the ventilator, number one, and see what expiration time the patient is having when the ventilator is cycling, as you mean to say.
Cycling, yes. That's right.
For NIV, in restrictive lung disease, we need to understand that the cycle sensitivity shouldn't be high. This mistake we shouldn't do for the restrictive lung disease with NIV. The cycle sensitivity should be the medium, and we should see what the I is to E ratio the patient is generating, as you told, and second, the synchrony. So we should start in restrictive lung disease with a TI max of around 1.2, and then we should see how the synchrony and the I is to E ratio or the cycle sensitivity is going on. So we can go up to a maximum of maybe 1.5 to 1.6. Yeah. So that's a great answer. So Dr. Kashmir,
moving forward, I would request Dr. Sharmila ma'am and Dr. Madhukar to please just quote the questions quickly so that we can have the expert opinion on both of these questions.
Sure. So both of these questions are finished, I mean, for the NIV settings. So you can invite the expert opinion on that.
Please, ma'am.
Can you hear me?
Yeah,
Yeah.
yeah, ma'am.
Yes. So I have a feeling for the first. I mean, well done for organizing this, and Deepak, thank you so much for inviting me. Um, I think for the first question, you actually wanted to very much know a bit more on the IPAP EPAP settings as well. Was the feeling I got when you were discussing in terms of restriction? We talk about a broad spectrum as well when you talk about restrictive lung disease. So I think in terms of the IPAP, EPAP numbers that you generate, if you're talking about a patient who doesn't have much muscle mass, like your motor neuron patients, you can manage with low pressure numbers. For example, you don't think about going on the IPAP about 20 probably. In our situation, we tend to start on low settings and then build it up, but you don't go very high on the IPAP numbers. Whereas if you talk about restriction because of obesity hypoventilation syndrome, it's still your settings, inspiratory time, all that is still the same, but you would still need a fairly high level of EPAP. Sometimes our EPAP numbers can be for very bariatric obese patients, as you can imagine. We have patients on EPAP of 16, and of course their pressure support and the IPAP is then going to be in the mid to about high 30s. So you have that range in your restrictive lung disease. That was one thing I wanted to add in there. But generally speaking, for the vast majority, you will be using sort of pressures around 4 to 10 to begin with, and then you slowly go up in terms of EPAP and IPAP, and then you're looking at, or for the vast majority, managing between 6 and a 16. The inspiratory time answer was brilliant, and you're right. You have to address both the fact that you use these in the acute setting as well as the chronic setting. Whereas my talk was very much on the home mechanical ventilation, like the chronic setting, but where we simply use a single lumen. So and the leaks and synchrony are very important things to address. But generally speaking, a lot of the machines that we have now fortunately have a range for the TI. So you're looking at setting that range between a 0.8 to 1.2 as a safe limit, and then you look at the cycling and triggering and how much, because a lot of the patients are now on the ST, so you can actually see how much the patient spontaneously generating, whether it's like almost 80%, 100% on the screen. And then you of course you have a chat with the patient, and then if you're happy, you set them up accordingly, tweak it. And you're right, generally speaking, for restrictive, you're looking at a TI up to about 1.5 in the vast majority, but in the very massive bariatric patients, sometimes very, very restricted, very stiff chest wall patients, you can push the TI a little bit further, provided you don't lose your synchrony. We have patients who are having TI up to about 2 on few occasions, but that is I say it's just broadly you address the questions very well.
It was a great input from you, Dr. Samila ma'am. In fact, it brings us to a point where we need to understand the component of obstructive sleep apnea in restrictive lung disease.
Yes.
And where it becomes an important determinant for fixing your IPAP or EPAP, even in restrictive lung disease. So it naturally brings me to question, Dr. Samir, please, where would you like to do polysomnography in patients with restrictive lung disease? And if you have decided to go for the PSG, how would you like to do it in restrictive lung disease?
Right. Now, when you're saying restrictive, I am leaving out the pulmonary restrictive part, that is the interstitial lung disease. I'm keeping it out because I think we should focus more on obesity, hypoventilation, and the neuromuscular deformity restrictive lung disease, so extrapulmonary types. So somebody who is, despite of on therapy, NIV therapy, or not on NIV therapy, diagnosed with say neuromuscular condition, and symptom-wise complaints of nightmares or sleep fragmentation or morning headaches or daytime somnolence, symptom-wise, and if we are able to do his spirometry and his vital capacity is generally less than 60%, or if the supine vital capacity is less than 25% as against his sitting vital capacity, then that is where we know that his neuromuscular deformity is taking over, and probably there is a sleep disturbed breathing in the night. Of course, if there is a nocturnal hypercapnia, nowadays they say that you can do. I haven't had the opportunity to do a percutaneous CO2 monitoring. I do not have this thing, so I go for a nighttime ABG and a daytime ABG in supine position just to see what is the level. If it is persistently above, say, 50-55, that means the patient is definitely having. And of course, if there are added right heart failure signs or pulmonary hypertension indicated in 2D echo, then we are probably heading for a sleep disorder breathing, which is also seen very commonly in obesity hypoventilation, where the daytime hypercapnia is a known thing. And so during the usage of NIV itself, if you start treating this patient with NIV, if possible, before I start him on NIV, I'll do a polysomnography and then maybe do a auto titration next night and then decide how it is happening. There are two types that again you can encounter. There could be upper airway obstruction included in that without any central drive issues, or there could be central drive issues. So depending on that, what you see in the polysomnography, you'll have to kind of design your therapy. One can also put the patient on NIV, make your settings whatever you're comfortable with, and start you can have the diaphragmatic belt and the saturation probe, the flow meter also connected, so that over 7-8 days you can have an average reading of how the patient is doing on NIV, and you can tweak your the settings as per what you are seeing, whether it is whether the patient's CO2 is improving, whether his daytime somnolence or headache is improving, sleep fragmentation is improving. ABG you can check after 8 days. So symptom wise, and so subjective and objective assessment you can do while doing a baseline polysomnography, and also doing a auto titration, you can say over 8 days time while using NIV.
Yeah, thank you, Dr. Samir. What we could get from you is, number one, if the patient has symptoms suggestive of obstructive sleep apnea, like sleep fragmentation, daytime sleepiness, and all, that makes one case where where we would like to do PSG. The second point that you come up with, when the patient is on NIV and you want to monitor the success of NIV in terms of the patient's hypoventilation, how the patient is doing, whether his hypoventilation has improved on NIV or not. That is one part where we would incorporate PSG. So, Dr. Samila, ma'am, when I was going through your talk, I could see one thing very clearly, that one criteria to put the patient on NIV in neuromuscular disease, particularly MND, was if the patient's saturation is still 90, more than 90, but AHI is more than 5. And would you like to keep this point before us, like deciding on an IV based on PSG in restrictive lung disease, particularly neuromuscular disease?
Yes, I think there is the issue in resource availability that you have to take into consideration. We in UK, because we have quite a spectrum of sleep centers. I think in India, most of your sleep centers actually have PSG on site available, and otherwise it's not, you're not a sleep center. Whereas in UK, we actually have the mini centers that are now branching out even into GP practice, and I think the world is changing in such a way that digital wireless sleep studies is going to be the future. So you won't be surprised in the next 5 years that there will be wireless PSGs available. And it's going to transform all these sort of diagnostics in lab. So you will find a group of our patients will just have just a pulse ox and your blood gas criteria. And coming to what Samia was saying is having just a paired blood gas the night before and the morning with a jump on according to your CO2 number, just a jump on up 7 millimeter mercury or above, or even 10 millimeter. That's good enough for your hyperventilation diagnosis. But of course, the AHI is what you need to know, which is what you add through the PSG. It doesn't necessarily have to be a PSG. It can be a holography or a pulse ox with a good eye. So on the pulse ox, just not just the hypoventilation. If you have a good eye in reading these pulse oxes over time, you can even pick central events plus your sort of obstructive events in there. So it really depends on your resource availability for you to get your data to say, is this overlap syndrome with a restrictive component? And the commonest overlap syndrome you're going to come across is the OSA with OHS. And then on the other hand, you will have your MND patients or kyphoscoliosis patients who will have OSA and maybe a bit of OHS overlap on top of it, because obesity is becoming so prevalent in these patients. So if you have OSA overlap, and if OSA is the predominant disease, and this is in the recent NICE 2021 OSA guideline, is that if the OSA is your predominant disease, actually a small group of these patients will simply start on CPAP, because we know that OSA is actually the predominant disease. And that's an important message that I think is about you select. This is where possibly clinicians have to maybe do it as an MDT and decide where you're heading with this patient. Then there will come a group of patients who that they do have significant OSA, but their neuromuscular component is such, the PCO2 jump and all of that symptoms, you have to take everything into account. Then you go on to your BiPAP, but you need a high EPAP for these patients. So I think it's those two distinctions that you can make, but it doesn't necessarily, I know you lab-based, you are very sort of polysomnography based centers, a lot of the centers in UK. So you have that luxury to be able to provide on-site PSG, sensor belt titrations. If you have the facility to Tosca titration, in UK, it's a bit different. So our guidelines will reflect that. But the take-home message for you is that, if you have a high degree of suspicion in those patients, and then you can decide, there will be a group of patients who you can actually start on CPAP. But if you're giving them the bi-level ventilation, then your EPAP has to reflect that, not necessarily at the start, because the patients may not tolerate, but so I think you do inpatient setups to these patients, so you can actually gradually up titrate it like that. We tend to do it in the community. I think I spoke to you about telemonitoring. Our telemonitoring machines, you can actually remotely increase the pressures over time. Patient doesn't have to come back to the center. So the way we do it in UK is slightly different, but the way you should do the diagnostics, probably depending on what resource available to you can decide.
Thank you so much, Dr. Simran. That was a great insight, and that brings me to a very simple question, where I would like you to recommend us in yes or no. If you find a discordance between the patient symptoms and pulmonary function test in restrictive lung disease, would you recommend PSG to all those such cases?
Discordance in the symptoms and lung function in terms of your
in the symptoms of hypoventilation.
Yes is the answer to that. I mean, it doesn't, as I said, it doesn't have to be a polysomnography, but at least a minimum of pulse oximetry.
Brilliant.
Because there is actually a fair group of patients who you will find the FVC is about 80%, but when you do the pulse ox, you can clearly see that they have, and sometimes the history is there, they can't lie flat. But but so you only will pick it. This is why I think in all guidelines you have your lung function criteria and your sleep study criteria, because you need the mix of it. The good news is, for the ones who with the good lung function, is that their prognosis is obviously better. But for you will miss the diagnostics if you don't do your polysomnography or your whichever the sleep study you have. It could be a paired blood gas to be as an initial screening.
Thank you so much. Dr. Kanis, can we take more questions in a panel discussion? What is the status? You are having questions from the audience?
I am actually overwhelmed with the responses I'm getting on because of the questions I have. I think it will take around like a whole night to read all the question and answer all the questions. So I would just take a few very important questions so that we have a wonderful discussion and people can take some things back to their clinical practice. So can we go through these questions?
Yes,
So,
sure, Kanis. The audiences have the questions. We should actually address them. This is really important.
okay, so the first question is from Dr. Shushant Kumar. He asks that if a patient is tachypneic and the respiratory rate is more than 40 per minute, so in this condition, can we apply NIV? Is NIV useful in such situations?
So I would
Very high
request,
respiratory.
yeah, I would request one of my panelists to come up with this question. The question is, the patient with restrictive lung disease is having high respiratory rate. The patient is tachypneic. Would, do you think that your NIV is going to be successful in these cases? Would you like to apply it? Yes, Dr. Samir.
Shall I
Please.
answer? So it depends on what time you are seeing the patient, whether the patient has just arrived in ER or ICU or it is 2 hours after your NIV. So if the patient has just arrived and since you are talking about restrictive lung disease, but I take this as a general respiratory failure thing, you should give a couple of hours for the ABG and tachypnea and hemodynamics to settle. But if despite of 2 hours of good ventilation, if this is the condition, then one should go ahead with intubation ventilation, depending on what the clinical scenario is. I'm not elaborating more on this because there are lots of questions to be answered. But it depends on what time you are seeing the patient. After 4 hours of NIV also, if this is the state, then first of all, check your medical management, what you're doing, check your ventilatory settings that you have kept, whether your diagnosis of whatever you're treating, whether it is COPD or OHS or ILD, what you are treating, you fix that up and then take a call on intubation ventilation.
Dr. Sarmila, to this question only, I mean, if you have the patient with who is having tachypnea, say the respiratory rate around 38-40.
Yeah, this is like the acute failure situations, isn't it? You wouldn't get it unless the patient actually has pathological dysfunctional breathing. You wouldn't get this in the domiciliary setting. I agree with Samir. I mean, once you decide that the patient is for full escalation, then you go for full escalation. If the patient is not if the ceiling of care is actually an IV and the patient, you've decided patient is not for intubation, then of course you just have to slow the patient down, and sometimes you use drugs like morphine to slow the respiratory rate, just so that then you get more effective ventilation out of your NIV settings. But otherwise, if the patient is for full escalation, we should intubate the patient.
And Dr. Samira, we have two different types of backup rate for the patients for restrictive lung disease on NIV. Somebody is having such a high respiratory rate.
Yeah.
How much backup rate would you like to put the patient on NIV with TI max and cycling? Like, so that we want the patient to be on NIV rather than going for the invasive ventilation. We try very hard to put these patients before.
Yeah. So I suppose, if the respiratory is very high and you are managing, you can, so technically we say just, a few breaths less than the actual respiratory rate, but you can't go into the 30s. Your maximum you can go is to the higher 20s in terms of your backup rate, and then you're risking auto-PEEP in certain situations. So you have to be careful. I suppose, you just have to fortunately these situations aren't that common. So the vast majority, your standard backup rate is so for the patient's rest rate, very, just try and match it in the resting situation. So, and that tends to work. But on one hand, you have to slow these patients down. so that you can then match it with the backup rate that you can set up on the ventilator. I think that's usually the approach.
Yeah, so message is very clear. With such a high respiratory rate, it's really difficult to put the patient on NIV and settings and all, and we really need to put the patient, really need to calm the patient down to put the respiratory rate a little down by treating the underlying disease and using some sort of medicines as Dr. Samira was talking about. So, Kanis, we can have the next question, please.
Yeah, I'll just ask the question directly to Sharmila ma'am. This is a question from Dr. Naeem Dar from Jammu and Kashmir, Srinagar. He asks what NIV setting to start with in a case of IPF with just hypoxia on room air. The saturation is around 94% on 3 liters oxygen, thin built, cachexic. He might be seeing this patient, I think, right now in his hospital, so that's why he's asking.
So traditionally, I think although we talked about restrictive lung disease, we put lung fibrosis out of the picture, but this is parenchymal fibrosis, and generally speaking, they don't necessarily need very high settings. So if it's thin build, not much of muscle, so most likely these patients have got muscle wasting because of the IPF. So you can start them on something like a 4 and a 12 and up titrate. They don't tend to need that much of they need, usually they end up needing entrailed oxygen with it to maintain the hypoxia. They don't necessarily tend to retain as fast as your COPD patients who are struggling to expire. So you can generally manage with a TI of somewhere around 1, and your backup rate, usually they are hyper ventilating a lot of these patients, so a little bit of a high backup rate, maybe 16, 18 to start with, and then you take it, and then you can probably gradually up titrate, depending on, some patients are CO2 retainers, of course, although generally speaking, a lot of IPF patients you will find is hypoxia is the main problem. It's just to reduce their respiratory effort and make them make use of the ventilator to more correct their type. Usually they're sort of borderline type 2 and usually more hypoxic, aren't they, the ILD patients, but they do end up benefiting a lot with the NIVs in terms of improving their quality of life, pulmonary hypertension and so on. I hope that answered the question.
Yeah, of course, that's perfectly and like very elaborate answer to this question. Now I'll move on to the next question, very practical question from Dr. Pallav Bhattacharya from West Bengal. In a CO2 retention scenario, in the patient suffering from neuromuscular diseases, should NIV settings be similar to the settings that we apply in a patient of COPD? What's your take, Dr. Kashmira? Would you like to answer this question? In CO2 retention scenarios in neuromuscular diseases, about the NIV settings, is it similar to the COPD?
It's almost similar to the COPD, but the mode of ventilation would be preferred mode in NIV setting would be in neuromuscular disease would be the pressure control mode, because this type of patient they have a chest muscle wall weakness and inspiratory and expiratory muscle weakness, and they do have a hypoventilation also, and because of that, pressure control mode would be the better option for this type of patient.
Dr. Kanis, coming to this question, I would like to make it very clear that the obstructive lung disease and restrictive lung disease, if both of these groups have hypoventilation, it's okay. But the physiology of having hypoventilation is entirely different in these two conditions. We really need to understand the physiology. If you are putting a pressure controlled ventilation for a patient with restrictive, for example, NMD with hypoventilation, as Dr. Samila was talking very nicely, that if the patient does not having an obstructive sleep apnea component, we really need to keep EPAP low rather than high, in contrast to the obstructive lung disease. Second, the patient would require high IPAP. The pressure support required in the restrictive lung disease is much lesser than compared to the obstructive lung disease. So here we need low EPAP, IPAP greater but less pressure support than the obstructive lung disease. Please do not prolong the expiration Even if the patient is having hypoventilation in restrictive lung disease, TI max we discussed a lot. And if the patient is still experiencing hypoventilation, hypercapnia despite being on pressure controlled NIV, then this is the time when we should switch to the volume control or volume targeted ventilation. So a volume targeted ventilation, if you are using, for the volume targeted ventilation, it's not the obstructive lung disease which will be benefited. If you're using a volume targeted ventilation, it has to be restrictive lung disease. You can have the expert input from Dr. Samila ma'am, please.
Ma'am, you would like to add something in it?
In terms of the, I think, Madhu, you answered the question very well. So for the COPD, extreme COPD group who are not that obese, it's remarkable how much IPAP they actually tolerate. So you wouldn't get that in your neuromuscular group, because obviously neuromuscular groups they do not have much muscle power to generate that degree of resistance, and it's exactly to do with the difference in the pathology. It is the degree of airflow obstruction and the time that they need for the expiration that differs. So the pressure support that the COPD group who are not that obese, still you sometimes end up needing a fair amount of pressure support. You're looking at an EPAP for around 4 or 6 still, but your IPAPs can go up to the mid-20s in that group. So there is that difference. So if you are more restrictive and neuromuscular, then generally speaking, between a EPAP of 4 to 6, it's very rare that if they do not have any element of OSA that we need a higher EPAP. But the IPAP, we can manage it within like 12, 14, 16, that sort of numbers in neuromuscular patients, and they're generally fairly stable unless they have a rapidly progressive disease, where you then, of course, it's the hours of usage that you go up on rather than the actual pressure numbers for the neuromuscular group. So there is that distinct difference because of the distinct difference in the pathology.
Brilliant explanation, ma'am. Thank you so much. But next, I have one question from Dr. Suprava Chakravarti from Jharkhand, Ranchi. She asks that is any cutoff value for peak pressure to be seen and being careful about in the case of fibrotic ILD, in advanced diseases of fibrotic ILD, I mean to say. Cutoff of peak pressure value.
So again, I think it is to do with whether you're dealing with simple, very bad fibrotic lung disease with muscle wasting, or whether you have patients with fibrotic lung disease overlapping with other conditions where you have obesity, maybe they've had osteoporosis, kyphosis. So if it depends on whether you have a mixed pathology or not. And if you find they have OSA, OHS, kyphosis, that sort of overlap with the underlying fibrosis, they tend to tolerate fairly high EPAP and IPAP pressures. And again, your lung fibrosis, again looking into, there is that risk of pneumomediastinitis, pneumomediastinum and barotrauma for simple ILD patients. They don't tend to need that much of high pressures, but you do find that some of them even can have spontaneous issues with barotrauma. So you have to be careful. But as I said before, you can manage with low pressure settings. But supposing they are overlapping with other elements such as obesity, kyphosis, or OSA, then you can go on high pressure settings for the ILD patients.
So now I move on to the next question. We have a lot of questions, so I would like to ask you one more from Dr. Naeem Dar again from Jammu Kashmir. Asks that high flow oxygen in restrictive lung disease as a bridge therapy, do you recommend? I ask Dr. Samir Gadde to please share some insights on this topic. Then I will come to you, ma'am.
Right. So bridge, that means I'm thinking that he's asking about lung transplant when you're talking about bridging. And when you're talking about bridging in restrictive lung disease, I take it as end-stage fibrotic lung disease going in for a lung transplant and requiring this. So yes, there are. It's all tailor-made. To be very frank, you can use a HFNO depending on whether the patient is tolerating NIV or not tolerating NIV. High flow oxygen itself isn't really the solution. It's like you are putting coins in a torn pocket. So you'll have to either give a augmented oxygen through HFNO, HFNC rather, or NIV. To just add to what this, I can take this as an extension to what Dr. Sharmila was answering. It is not written anywhere or not a thumb rule, but what I follow as a practical this thing is if it's a cachectic ILD, you can start with a EPAP of say 4 and IPAP of 10, 12 above. Generally never crossed 14 centimeter. They don't need more than that. If it's an obese ILD, then somebody who's above 60, 70 kg, we can straight away safely start with 7 or 8 of EPAP and keep your IPAP 4 plus above that. So we have given up to, as madam had said, up to 18 or 20 centimeters also, even in Indian patient. So if you're talking about bridging, the ideal bridging for a lung transplant patient is ECMO, but obviously that's expensive. So if you're talking about mechanical ventilation or oxygen supplementation, it has to be either HFNC, high flow this thing, high frequency nasal cannula, high flow nasal cannula, or one of the modes from NIV.
Ma'am, what's your take on the bridge therapy on
Yeah,
HFNC?
so in the UK setting, as you know, we do have patients who are bridging to transplant from the domiciliary setting. And of course, the vast majority of them will be on NIV with home oxygen. And we do have the capacity to deliver your standard NIV home oxygen up to 10 liters on our standard oxygen concentrators. But there is a small group who actually need more than that, and they do end up having high flow oxygen on top of it. And if they're not retainers, and some of them actually aren't, I mean, I do have a few patients, but they don't survive for long unless you transplant them, of course. But they can manage with high flow oxygen, and they don't still retain. You're looking at devices that deliver high flow oxygen without the ventilator mode in it, just the home high flow oxygen.
So moving on to the next question, what is the side effect of aerophagia or aspiration in restrictive lung disease vis-a-vis COPD? Dr. Madhukar, you want to add this? Then we'll move on to Sharmila ma'am for this question.
Can you please repeat this question?
Yeah, side effects of aerophagia or aspiration in restrictive lung disease on NIV vis-a-vis COPD.
So that's a good. The point is, he is asking about the when the patient is being put on NIV and the patient has developed aerophagia, whether it's more common in restrictive or obstructive lung disease. Is it the question?
Yeah, the question of the difference between the settings in restrictive lung disease.
Aerophagia is something which is has been demonstrated as one of the adverse event being associated with of NIV, whether you ventilate the patient with obstructive lung disease or restrictive lung disease. So aerophagia is something which doesn't depend on the underlying disease, underlying lung disorder. So aerophagia is something which is, if the patient goes on to develop aerophagia, we even do not know at what pressure setting which patient is going to develop aerophagia. So if the patient is found to develop aerophagia, either we take the patient off NIV for some time and we try to put the patient again in the lower pressure, specifically lower IPAP, and see what's happening. If the patient is developing aerophagia even with the lower IPAP, then we cannot use an IV in those kind of patients. So it's not about underlying disease.
And I just want to add on this aerophagia is more towards the what type of mask patient is using rather than what underlying condition is. So it is more with full face mask and face mask rather than this underlying condition. to add on this, Dr. Madhukar.
Thank you, ma'am.
Ma'am, you want to add
Yeah.
something to this?
I think between the two of you actually answered the question. So the mask is as equally important and as dropping the pressure setting. And generally, I would say the vast majority you can manage between those two options. So you drop the pressure settings. If that doesn't work, you change the mask. And then, of course, when you look at mask options, there's quite a few new orofacial masks that gives you just a very minimum cover, which is just a mouth and just the nostril, and that sort of mask sometimes takes care of it. So generally speaking, between those two, you can manage the orophagia, particularly in the home setting patients who are mobile, who can walk about. I tend to give them some breathing technique exercises and get them to walk about. That also helps, so that you can still carry on giving them the home NIV, and they gradually acclimatize to it with time.
Okay, so now we move on to the last question. We have a lot of questions, but I think that will be the last question for this session. In CPFE, Dr. Kashmira, what is the preferred mode according to you? And then we'll ask the same question to Sharmila ma'am after that.
What is the question? Sorry?
What is the preferred mode in CPFE patients?
CPFE patient. Okay. In CPFE, your preferred mode of ventilation again is BiPAP spontaneous time mode, because this is a condition in which restrictive and obstructive abnormality is there. So preferred mode is NIV spontaneous time would be better option.
Ma'am, you want to add something in it?
Yes. So I think you have to really look into which is the dominant disease in CPFE. So that is your forward flow volume loop and your FEV1 ratio really is helpful. You will have a group of CPFEs who are very emphysematous, and they behave more like your COPD emphysema group. On the other hand, you will have a group of CPFEs who are very basally fibrotic, and it's just a bit of central lobular emphysema here and there. So they will behave more like your IPF group. So I think you have between your CPF, you will probably have these two groups in it. So that is your eye on your imaging and your lung function that tells you these two groups. So identify the two groups, and then the ones who are more for your COPD type, you manage according to your COPD numbers, and the ones who are more on your IPF spectrum, where you don't see much of obstructive element, then you manage according to, you will find then between, there's always that gray patient who is in between, but I'm just telling you the two distinct groups, because we've now read through the numbers for these patients. You know that there are two different types of numbers you go by in terms of inspiratory time and so on, backup rate. But then if in doubt, you start at low settings and you can always go up.
So Dr. Madhukar, you wanted to add something?
Yeah, so this is really an important question. When you have a combined pulmonary fibrosis and emphysema, and Dr. Samira ma'am was right, most of these patients require NIV because of the underlying COPD rather than pulmonary fibrosis, speaking in general. But otherwise, really need to find what predominant disturbance is. But you always start slow and then go up high. One particular point that I would like to mention here is when you have CPFE patient, one parameter that has to be taken consideration is the rise time. When you apply an IV, in these kind of patients, you want your pressure to be delivered without wasting your time. And therefore, we need to keep the rise time shorter. So in case of CPFE, we keep our rise time, even with presence of restrictive lung disease, somewhere around, even in the presence of obstructive lung disease, somewhere around 150, 200. We do not go to more than 200 or something like that, opposed to isolated obstructive lung disease.
So now I think we have a lot of questions, but I have to stop at this point of time, and I'd request Dr. Talwar sir to come live and just say a few words that what he thought of for the execution of this program, and what he thinks right now, what is his take on this, what about the discussion, what he felt, what about the audience reaction, how many number of questions that we got. So I want to know from his side that what he thinks about this session which has just happened right now.
It's a great experience. In fact, I have learnt much more on this lecture at this symposia rather than when Sharmila was live on PAX 24. And Sharmila, thanks a lot, because lots of questions were not answered. I'm really very happy that so many things related to NIV which came up in today's discussion have been clarified so well, and with Samir and Kashmira pitching in, and Madhukar also putting his best views. And I wish I had more time, Sharmila, to discuss many other things. And the kind of questions which have come in from all over, it shows that, the amount of interest as well as how difficult it is, the topic. And I think very beginning you said that one size fits all is not correct here, and you have to really sense your patient, that what is the major issue in that patient. Is it the work of breathing? Is it the hypoxia? Is it the hypercapnia? Is it the muscle factor? It is the lung factor? It is the chest wall factor? Everything accounts for how you set your NIV and make it as total success. And everybody wants success in NIV, because that's the most gratifying thing which you can actually offer to these patients, because once intubated and mechanically ventilated, chances of getting them out is almost nil. So this is the only time, and we have seen in neuromuscular diseases, they go home on NIV and they keep coming for years together on NIV, but once they are put on to mechanical ventilator, that's the end of the story for them. So I think this is a wonderful symposium, and I have relived it more than PAX 24 actually. I'm sure, Sharmila, you would have enjoyed it also, because all questions and panelists had time with you today, and that was the idea of bringing PAX Web Symposia with a live interaction with the foreign faculty, with our expert faculty, as well as our expert faculty in India as a panelist and moderators, and then spread it across the India with the help of our educational partner, that is CIPLA. Thank you everyone for joining in, and thank you Samir, thank you Kashmira, thank you Madhukar, thank you Kanishk, and I have no words to thank Sharmila, who immediately agreed, despite it being newer, it's a newer weekend in UK, and I know that how important it is, but still you gave time to us. Thank you very much, Sharmila.
I have enjoyed it as much as you have, actually. It's
Yeah,
great to be
before
part
we
of your
leave,
family.
before we leave, I just want all of you, all the experts, panelists, and Talwar sir, to give one line message, that what message they want to give to the audience in this topic of NIV in lung failure, so that they can take that take home message from all of you. I'll start from Dr. Samir.
Oh, it's a tough task, Dr. Kanish. I was waiting for Dr. Talwar to say something. I would have said yes, the same. Um, uh, it's an interesting field of NIV and restrictive lung disease. It's ever evolving field. Keep all your options open as far as modes are concerned. Keep your eyes and ears open about every restrictive patient, whether he has cachexia, obesity, obstructive sleep apnea, right heart failure. You have to be vigilant all the time. So keep monitoring your NIV in the restrictive lung disease patient, extrapulmonary, vigilantly.
Dr. Kashmira.
I would like to say, in our clinical practice, we are seeing many patients of chest wall deformity, kyphosis, kyphoscoliosis, and all this patient, but we don't look into detail. So I would like to address we should have a clinical history, detailed clinical history, and detail this spirometry function, and we can provide them and treat early all this over the period of time complications, so we can give them better quality of life. That is what we should do for our
Yeah.
restrictive lung patients, because these are the patients which are least bothered and neglected, frankly speaking, even in our clinical practice also. And neuromuscular disease, obviously we are looking into that, but this type of patient, chest wall deformity, is really major. We should look into the detail.
Dr. Madhukar, what do you want to? That's
Congratulations, Dr. Kanis. You are the brainchild of this international symposium. It went really well, I guess. I am a great fan of Dr. Deepak Talwar and Dr. Samila ma'am, and I would go with whatever they say. I am just, kind of naive in all these things. So let them speak, and my whole heart, whatever my heart wants to speak, will be the same they want to. Thank you so much.
Dr. Sharmila, ma'am.
It's actually a very simple and important message, hoping a majority of these are registrars. It is to actually educate your neurology colleagues, your general physicians, just to say that this is out there, that they need to be vigilant. Just a simple use of a spirometry and a pulse oximetry is what they need, and to refer to them. And then as registrars, when you become consultants, you will pick more of these patients, and if you imagine across the globe, if that happens, how much longer these patients can survive.
So, Talwar sir, when are we coming back with the new program of International Web Symposium from PAX 24? Hot topics highlights.
Next month, January, last Saturday, which is 25th of January, it will be again there. And I got a very wonderful, insight from Sharmila that you need to look into imaging, you need to look at physiology, you need to look at lung functions, and then actually that how and what the NIV will work in an individual patient, and I think how to navigate your path in that patient to success. All this information needs to be kept in mind and be on the bedside of the patient when you start for a little more longer time than you generally give, and that is the role of the success of NIV. I remember that in 2000 when we started NIV at our center, it was very, very naive at that time actually, and we had to learn most of the things by ourselves, and the only other thing which helped us to learn was the book by Dr. Anita Simons, who was your teacher, and you gave your gratitude to her right in the beginning, because she was the biggest name in late 90s and early 2000 as the NIV, promoter of NIV and home ventilation. Thank you everyone, and back to Kanishk. If you want to announce the next one, fine, and then we can close.
Yeah, so I'm like very happy, mostly because of the execution of the program. Of course, that's very, very important. But above all, the reaction from audience is tremendous, and everybody was asking me since last 5-6 days that when we are going to see this and what's the registration link. And Cipla helped us a lot in execution of this wonderful program. And now we promise you the next one will be on 25th of the January next month and next year also. And that will be the first of 2025, and we'll keep doing all these activities so that we able to transform this pulmonary medicine and share our insights and knowledge. So I am very, very thankful to all of you who has attended this online session, and few of them are attending physically as well. So I'm like very happy, and I want to thank all of you from the bottom of my heart. Thank you so much.
Thank you everyone actually.
Thank you, sir. Thank you, sir, for involving us. Thank you so much.
Thank you, Kashmira. Thank you, and Sharmila. No words for thank you. We can go off air, so you can take us off air so that we can officially say thanks to everyone.